So it's a really wonderful question, and it's actually a great time to be in cardiovascular disease, given the number of new treatments that we have available to us that we really didn't have available to us even just a few years ago. Within the coronary artery disease and peripheral arterial disease grouping, really some exciting medications have come out, specifically medications including low-dose antithrombotics, the anti-glycemic medications, and of course, dyslipidemic medications. All of these have really been a wonderful addition to our current toolbox for our patients. When we're looking at antithrombotics, obviously the low-dose rivaroxaban, the vascular protection dose of 2.5 milligrams BAD has really been a boon, specifically within the peripheral arterial disease, but also high-risk coronary artery disease, now reflected in the guidelines. We really have been looking, for years to have a better treatment for patients with peripheral arterial disease. And now, of course, we have the rivaroxaban and others. But the rivaroxaban has been really beneficial in preventing, I think, some of the most dreaded complications, including stroke, including amputation, and then, of course, having an effect on mortality. This is something within the COMPASS trial that we will be publishing hopefully relatively soon. And this is really underlined by the Voyager PAD data as well, showing that earlier treatment after revascularization has similar cardiovascular benefits, really showing that we should be using this more aggressively in our PAD patients. But in addition, we had seen within the hyperlipidemia segment, the PCSK9s, now these data are a little bit old, but no less robust in that we're seeing significant benefits with peripheral arterial disease and use of PCSK9s, finding the lower is better, and really thinking that LDL has almost become a toxic substance. It's something that we should be avoiding, and lower is better. We really haven't found out what too low is quite yet. But specifically within PAD, the highest risk patient population, we should be going lower and lower. And now we have new ways of doing that. In addition, talking about things that we're somewhat uncomfortable with, the dyslipidemics have really come on. And now we have multiple lines of evidence and multiple compounds, the SGLT2s as well as the GLP-1s available to us, which beneficially affect cardiovascular events. And it looks like the SGLT2s have actually become quite beneficial as a class effect. And so something that we can be used and really should be using more and more. It's just getting cardiologists used to using a dysglycemic medication, a glycosuric medication. Fortunately, there doesn't seem to be as much hypoglycemia in the patients using SGLT2s. And so something that we could potentially become very used to, and many of us are in our practices. So also a great question. So talking about some of the cutting edge therapies that are now also guideline recommended, again, coming back to the use of antithrombotics and being more aggressive in our high risk patients, and then really defining who those high risk patients are for coronary artery disease with the European Society of Cardiology chronic coronary syndrome patients. And so using, the low dose rivaroxaban that we had talked about before, the 2.5 milligrams BAD in patients post MI, looking at either prasugrel and or ticagrelor and or clopidogrel for those patients have shown to be beneficial in various ways. Mostly the antiplatelets have more of a benefit on myocardial infarction. The low-dose antithrombotic has more of a benefit on peripheral disease, specifically stroke, but we really are seeing added benefit. Of course, the guideline recommendations regarding dyslipidemia, now using more PCSK9 and being more aggressive with ezetimibe is also great. And then, of course, there are the new kids coming around the corner. One of which is the inclisiran's looking for medications that may be once every 6 months, such that you're basically getting your lipid flu shot, if you will, your cholesterol flu shot. Compliance with that is actually going to be very, very good. And if the phase 3 trials show that that's beneficial, then that's great. Although I understand that it is going to FDA for earlier approval, even prior to the phase 3s. I think COVID-19 has really been a hindrance on multiple levels for my practice and for my patients. Obviously, especially when this first started, I'm not seeing my patients quite as often. We're doing a lot more telehealth, and in some ways that's good, in some ways that's bad. I think the physical examination for many of our patients, we do pick up things. We do pick up things like carotid bruits. We do pick up peripheral arterial disease when we actually take off the socks and feel. So we do miss some of that and some of the in-person interactions. But what about the thrombotics and cardiovascular disease? This is truly a hyperinflammatory state. We've seen in our hospital and been reported elsewhere that many people were just waiting to come in with their myocardial infarctions. I had a 62-year-old gentleman that waited 3 months to come in after his rather large anterior myocardial infarction, and he was even a physician back in Pakistan, but only came in after he could only walk 20 feet and could barely make it to the bathroom. He thought it was time to come into the clinic. So I think it's affected people in multiple different ways. I think we're going to have to see what kind of effect this has on cardiovascular disease long term, just because this is such a hyperinflammatory state. Are we really driving atherosclerosis? We don't have those data yet, but we sure have a lot of anecdotal evidence that there are individuals that have increased risk for pulmonary embolism, the COVID toes, microvascular disease. What is all of this going to mean over time? I don't know. So for now, we're taking a watch and see, but it has really had a fundamental effect on how I interact with patients now. So hopefully the vaccine will allow us to come back to some kind of normalcy. Yeah, so I think it's, again, it's a very, very exciting time to be in cardiology and cardiovascular disease because we have these new treatments. The biggest issue is us really getting off the dime and actually treating our patients more aggressively when appropriate. If we have a high-risk patient sitting in front of us, the ESC got it right. They said this is chronic coronary syndrome. This is not stable. Don't wipe that from your vocabulary, because these patients have an indolent disease. It's almost like a slow growing cancer, and we should try to treat it as such. If we have a high-risk patient sitting in front of us, we need to be as aggressive as we can, because when we meet those patients in the ICU, we failed. So it's time to start thinking about being more aggressive for antithrombotics, being more aggressive for dyslipidemia therapy in our diabetics, being more aggressive for our patients with lipid therapy. So, and we should do that multiple times this week, not next week, this week, because that starts you on your road to recovery for your patients and decrease risk for having subsequent cardiovascular events.